Hi, everyone. I'm Marina Temkin. I'm a reporter with TechCrunch. I cover tech and startups and spend a little bit of my time on healthcare, not all of it. And we have wonderful panelists today. They're not there. We have Nicole. She is a senior vice president, chief learning and member experience officer with CHIME. Then we have Shri. He's a chief operations and information officer at Longevity Health. And then we have Simi, managing director at Innovaccer. And finally, we have John. He's a CDAO at Cone Health. So we have representatives from kind of across the spectrum of healthcare. And I might start with you each sit at the intersection of technology, operations, and outcomes. To level set, where are you actually using AI today to take administrative work off people's plates in your organizations? Shri, is it okay if I start with you?
Sure.
Longevity stitches payer-provider realities. How have you structured ownership so pilots don't die at handoff?
So just before we get started, I just want to give you a bit of background of Longevity. We are a rather unique health plan that takes care of patients beyond the age of 80, 85. So think about your grandmother who is in a skilled nursing facility, who cannot basically take care of daily activities. And we are taking care of that patient population. We have a contract with Medicare in order to deliver services on a value-based care perspective. So we file a model of care with CMS in order for us to help that particular patient population. So from the question, if you look at it, right, we are both a payer and a provider, a true value-based care player in the marketplace. And when I say that, we mean we run a health plan. I run a health plan. We've got operations, claims, call centers, like every single health plan does. On the other hand side, we also have an EMR that is used by several clinicians to take care of the patients in the institution buildings that they actually go to. When I talk about buildings, it's basically skilled nursing facilities. We are in about 14 states, so we've got a lot of clinicians going up and down to the buildings and taking care of these patients. Now, when you talk about the conjunction of provider and payer, you're talking about the data for that particular patient coming through together both on the clinical side as well as on the payer side. And that is where we actually see the benefit of bringing it together, using some level of autonomy and making sure that the workflows can work, because we have the full breadth of data of that particular patient that comes together and helps the clinician understand what they need to do on one hand side. On the other hand side, we have RAF, HEDIS, quality reporting that we need to do. So we make sure that that information flows through to understand how the capabilities around prior authorizations, the referral process where you have a clinician referring the patient out to a particular specialist, because we have contract with the specialist, right? We are a plan, so we have a network contracting. We contract with the network, so we bring it all together. It's such a big capability that we offer for that particular patient population. Very high acute, we have a lot of people who are acute, and we lose 3% of our population to death, which not many people understand in this world, right? So it's a very different mindset, it's a very different population, and that's how we take care of them.
So follow-up question, longevity focuses on high utilization institutional populations. Which administrative or clinical workflows that were surprisingly automation ready and which still need foundational work?
So in our case, because we are a plan, we use a lot of prior authorizations to make it work. We have a lot of requests that we get for, because our patients are in the hospitals a lot. Our, what we call it, admits per thousand, which is a very standard number that is APK, which is standard number in the industry. We have a lot of physicians asking us for prior authorizations. And that process takes a lot of feedback from us. And not only us, we don't have a panel of specialists that we need in order to get these authorizations approved. A standard CMO cannot authorize a particular treatment or procedure if they don't understand. I'll give you a simple example. A skin therapy for a patient who's got extremely high sepsis type scenario that they have to get benefit of. We don't have a dermatologist on the panel, so we have third parties that actually give us that capability. So the workflow actually is a little bit more difficult to administer. So we built a workflow that takes our authorization, goes to our clinician, and then passed on to a third party, brought back into our environment, and then our process allows that particular process, the authorization to flow through. Now, if I can automate that entire process, because these treatments have to happen with that particular patient because they're high acute. So what we do is we run that process through our model and get the feedback back to them in a matter of a few minutes. That cannot happen without AI. That cannot happen without some sort of automation and autonomous capability. I mean, I was just reviewing the book that we had here that Abhinav wrote, and if you look at on page 63, he talks about the anatomy of an autonomous workflow. And almost all of this stuff we do, and we've been using the DAP, which is the application platform from Innovaccer, to make it work from that perspective. The next thing is for us is to get on Gravity.
Great. So now we'll hear from a system. John, how do you justify AI investments to a CFO? And can you provide a single metric example?
So investments in AI, I think we're talking a lot about what do they look like? We're doing testing, we're doing piloting, and you asked about a single example or maybe even a single metric. And even as an analytics leader, I don't know how we start to measure this, but it really talks to me about productivity. You heard earlier the work as a Ryzen affiliate at Cone Health, the work that Justin and Sham talked about, productivity from 30 to 45 minutes down to 1 minute. That's a real shift in productivity. Some other work we did late last year, we had our coding team collating manually from multiple sources, automated that process, able to bring it down, and when we did some studies on it, we were saving 2 hours a day per coder. That team had 9 coders. That means that's 18 hours a day we're saving. It's over 2 FTE. So I think one of the challenges when we talk about this from a purely financial is, well, that means we're going to get rid of all these employees. How many people have had that question from a leader, a CFO? We're going to automate this and we're going to be out, we're going to have a whole part of our workforce. Yeah, I'm getting some energy here. We've got to, this is our challenge. But at the same time, are we thinking about the other investments needed to be good at this automation? What are we investing in understanding the risk of using AI, particularly in clinical environments? Are we thinking about the added capabilities to the teams to develop this or to work with partners like Innovaccer? So I think it's really going to be a shift. We've got to have our eye on productivity as a single metric, but we have to ask ourselves, how are we measuring that? And we're also understanding that we're moving what you might say is certain parts of the labor that we're adding directly to the care towards a lot more care experiences. And care is really a uniquely human experience. So how do we think about that? So a single metric on productivity, and we've got to keep our eye on it.
So human replacement is definitely not the metric yet.
Is not the measure.
Where do you still need to invest before workflow is automation ready? There are specific areas that are the most pressing need.
Yeah, I think as Shri talked about there, a lot of the work is understanding what that process is. So how many of us feel in healthcare that our processes are really standardized across our various practices? If you were part of a delivery system, you walked into every practice, would you get the similar experience? No. I see a lot of shaking of heads. If one of your back office teams in different practices or in different departments, inpatient and outpatient, similar processes, but we've not standardized them. I think as we look at automation, agentic AI, AI agents. We've got a lot of work to do around standardization first. So I think the biggest challenge to really getting the productivity becomes the challenge of how do we get the process standardization? How do we then turn that into the automation? We free people up to connect with our patients, and then we have to have a team that's studying and understanding, are these working? Are we improving? So I think there's a lot left in healthcare in a lot of environments that really require us to think about process standardization first.
So John,
Yeah.
you asked a question, right? Standardization. I mean, if you look at it, right? I mean, every single entity we talk to will tell you we are unique.
Exactly.
We offer a product that's far superior than every other competition in my locality, in my county, in my state. I mean, any health system will tell you that. I mean, I used to work for a health system, so I know. The worst part is, it was a 15 hospital health system, and every CEO of the hospital said, we are unique. I'm like, guys, you can't be that unique if you belong to one health system. You're using the same Epic, you're using the same product. But you're right. I mean, standardization has to start, and then AI can kick in from that perspective.
Yeah, couldn't agree more. And I love that story because I think that is our reality. And we need to deliver a differentiated experience around our care. But I think we've kidded ourselves about what can be standard and what really is that differentiated experience. And we've allowed things that really can be automated to be thought about as that differentiated experience. And that becomes a challenge. And that's a different type of thinking than just being at the bedside or being in our practice.
Thank you. Nicole, I'd love to hear from an independent body. If budgets tighten further this year, which AI investments survived the cut and which ones disappeared?
Thank you, and thank you for having us here. I am from CHIME, and if you don't know what CHIME it is a professional association. We have CIOs, CMIOs, CDOs, whatever the acronym is today. We have members. There are quite a few members I know in the audience today. But we hear a lot from all of those leaders right now on the challenges that they're facing. Everything that was said this morning, very valid problems. Everybody's facing them. They're all trying to figure out what that is. Is there anyone, show of hands, who's getting more budget this year? No, I didn't see anybody. So I think it's probably realistic that budgets will continue to tighten. And this is just that classic people, process, technology problem, I think. And we've heard process already mentioned. You also mentioned people. I think the things that are going to survive and the things that people need to be focusing on is making sure that you're aligned with all of your different partners. And so you've got to really define your problem. What's the problem that everyone's willing to actually go after? So if you think you can solve, say, pre-op, and that's the thing you want to solve, is your clinical team on board with you? Is your administrative team on board with you? Is the technology team on board? Because if any of those aren't, you're not going to be successful. And so I think a lot of it comes down to things that we aren't all taught in school. We're not taught how to build allegiances. We're not taught how to bring people along on that journey. And so I think from our perspective, we do really try to help people focus on how can you really define your problem, and do you have the right team at the table to actually execute? So I think that people, process, technology piece is so important. And technology is usually the least of the problem.
I mean, Nicole, if you had asked the question the other way around, right? How many of you guys are getting budget cuts because your CFO thinks you're deploying AI?
Yes.
Exactly.
Then we got a lot of hands up,
Yeah.
right? I mean,
Yeah.
that is how the market is today.
Yeah.
So when you deploy something like AI, there is this magic potion that somebody drinks in the process in the finance team that they think that all of a sudden they can cut budgets. I mean, that's how the concept is.
Yeah.
And
Go ahead, Nicole.
don't forget too, the maintenance of all of this
This
is
is
actually
what-
going to probably increase some of those costs, but I will bet most CFOs don't want to hear that.
Yeah.
At least
No,
my
I-
experience, they never
I
do.
really love that. I think it was a point I really want to make is it costs money and skilled resources to maintain AI. If we're going to monitor these over time, we're adding to our risk and compliance teams to understand these things. So there is a shift, and I think it's really important. I think one of the other things as you were talking that I'd like to push on a little bit is how many people feel that we're automating some bad processes to begin with as well? We got lots of energy there. We were doing some work.
We did that with EMRs, John. I mean,
Well, is
you take
this an
every EMR and go,
opportunity?
I want the EMR to work exactly like what I did on paper.
Absolutely.
I'm like, why you implement an EMR on that then?
Yeah.
Makes no sense, guys. So the same thing happening in AI.
Absolutely.
I want this AI to behave exactly like what it used to be when I did it in my EMR. I'm like, that makes no sense.
Yep.
Then why you deploy AI and LLMs and models and everything else associated with it?
Right. I love that. And I think, Nicole, that gets to your comment about we're not taught. We don't have teams, workforces to think about how does technology allow us to do a different process. And I'm going to keep on pushing on get our team members, our workforce, our colleagues, our friends connected to our patients and communities. That's what we have to free up. The hope of this is that we get rid of this administrative burden, but we have to name it. We can't just reproduce it with AI. We did a project where the idea was we could automate the first pass of writing our responses to denial letters back to payers. We asked the question of, shouldn't we be talking about why is this a denial in the first place?
Yeah.
So we've got to be open to that.
No, but you can use ChatGPT to write a better denial letter, you know? That gives you 10 marks more than the other guy because that guy is not going to go do ChatGPT. He's going to have a standardized letter. But now, guess what? You'll get a better response. Maybe your denial gets overturned, which is fantastic, right? That, my CFO will be like, yes, we should do that. Everybody should get ChatGPT. Yes, great.
So, quick question while we're about this is for Sheree and John. Are the CFOs telling you that they're noticing cost savings or not yet?
So there is this perception that there is cost savings. Seriously speaking, the cost savings is not going to happen immediately. The cost savings is going to happen 3 years down the line.
Yes.
Let me tell you. I mean, it's not even 27, 3 years down the line. And the reason why I'm saying this is because, I mean, if you take a payer, the providers are getting smarter by putting in every possible code so that they can get paid. Absolutely agree. So what's going to happen is you're going to get more voluminous claims that's going to go through the payer system. The cost is going to go up for a period of time before you see the capabilities. The payer has a lot more capabilities around denials, around authorizations and everything else. So he's going to make it faster. Great. Okay, you send me this. I'll deny it in 30 seconds. I'll send it you back. Great. That doesn't help the problem.
That does not make the health
doesn't
and
make
well-being of
sense.
our communities any
Exactly.
better.
So that's where we need to think about your cost cut situation is we need to think about long-term benefits. We can't say, oh, let's spend on AI so we can cut cost here. And the other thing, I mean, everybody seems to think that these AI engineers are just walking down the street, just go grab a guy and drop him in the back, right? It doesn't work either.
Right.
So people need to think a little bit
Well,
differently in terms of how you deploy solutions.
Yeah, I just wanted to add that, I've been collecting some data points as they're all speaking, so it's been good. Smriti here, lead managing director, lead the Gravity platform, right, which takes us all from the state of messy data points to obviously the autonomous state, which is agentic, right? I loved, Nicole, that you mentioned that we are not trained to get buy-in and build alliances, because when we talk about enterprise scaling, the key problem is there's siloedness, right? There's fragmented data, there's fragmented incentives, the CIO doesn't talk to the CHRO and the supply chain, and all this, wonderfulness happens. But when we unlock that, the only time we unlock that, in my experience, leading large digital transformations, which is, the consulting world and north of $100 million deal, right? That only happens when you bring in the 4 or 5 leaders to the circular table, and they lock in hands, talk about how they want to change IT, how do they want to change supply chain, and most importantly, that they have a common outcome that they want to drive for the enterprise, not today, but 5 to 10 years down the line, right? And when I took the role just a few months back to lead the platform, what was exciting to me that it's not just a data and AI platform. To me, it is an enterprise alignment platform because it does bring all leaders together. It allows a one-stop shop, and for CFOs, a one throat to choke, for outcomes, to look at a glass plane, to understand where the issues are happening, and to drive collective leadership and also vendorship. I know, Marina, you and I were chatting about the different vendors and what's there. But the problem is just that, right? There are too many AI point solutions, there are too many segments, and people can track the ROI. But if you had this one data platform and one way to scale AI, and I talk about this quite often, I'll stop after this, is the famous thing, which is the trampoline effect, right? Who in the room, when they're kids, maybe if you're like me, you'd still like the trampoline. How many of you like trampoline, jumping on a trampoline? It's fun. Right? It's fun, it's liberating. It gets you to a new height faster, right? So for us, the platform is the same thing. It gives you the springboard effect with pre-built connectors, pre-built agents, pre-built dashboards, because we want leaders to have fun, right? Data and AI, all this work like Shri is doing, John's doing, Nicole's doing, it's hard grind. It's like 24/7, right? We want this to be fun.
Yes, Simi, you and I talked last week about this orchestration idea, though. So I think that that's becoming more and more important, that any leader, whether they're in finance or they're in the clinical side where the technology really has that ability to orchestrate. I really liked that concept that you brought forward, that you can bring these use cases, you can bring the solutions forward, but if you don't get the buy-in, they're going to fail out of the gate. And I think back to the kind of your question about tightening budgets, you're not going to get any more dollars if you can't show success. So really be thoughtful and deliberate in the use cases you pick, and pick some where you know you're going to have some wins, even if it may not be the biggest financial return or the one thing that everyone's asking about. Maybe what everyone's asking for won't be successful and you know that. Pivot to what you know is going to work.
Nicole, building on that and connecting these ideas, so we've got one thread about sort of short-term shifts that can call it show ROI, but probably doesn't change how we deliver care all that much. It improves how we administer this complex thing called healthcare. And then on the other side, you're sort of painting this picture of, is this an opportunity with these technologies that are going to take 1, 3, 5 years to invest in to chart a different future? And I think we're in this tension of balancing those two things. And if we're not thinking about both sides of it, if we're not aligning incentives for the long term, many of the people here come with a value-based care, population health background interest. Does this give us a scale in value-based care that we've not been able to see before? Does it drive alignment? So there's become questions about how do we take this point in time and accelerate that work?
And I think that's interesting, John. I think human psychology is fascinating to me, right? We think about AI as a cost. We don't think about it as an investment, right? No one in this room had put $1 million into S&P today and expected it to double tomorrow, right? You look at it compounding, you look at it the 5-year trajectory, the 10-year trajectory. Yeah. Why isn't that same mindset being applied to AI, right? It's for us, like the Gravity platform is that one-time investment that gives you the dividends, that gives you the ROI, that gives you longitudinal impact, right? Impact is not just the money saved. It's how do you empower your teams and your healthcare leaders to really get to that point of care in the right way, the right time, and with efficiency. Like that is the high impact for us.
But then how do you measure? What is the impact?
So for us, right, we look at high impact, low risk use cases because end of the day, we are not a Waymo. We are obviously touching lives and changing lives, right? It is healthcare. And so we start from administrative, we get into operational, then we get to clinical, right? We do take it seriously. And I say this often that data is good, but data, we are not physicians, we are not surgeons in the front row, but we do understand that each data point is a life point. It can change lives, sometimes it can save lives, right? So we take it very seriously. So we start from administrative, like John and Stream, messaged out that that's why we want to make the change, right? On the productivity, on the efficiency, and show the ROI in terms of impact and outcomes in that line of work, and then eventually, I think it'll be clinical.
I mean, if you take what we saw this morning from the Innovaccer team, and what we've been seeing in the marketplace for the past 10 years, right? All of us were hitchhiking on this EMR, EHR, oh my God, we got to go do this. My question is, has that delivered any value to healthcare? How much of the data actually been used to help care for us? Us meaning us as a population, us as a community, us as a society. And then, having invested whatever billions of dollars in that model, is it just becoming a way for us to bill and get paid? Or is it a way to transform healthcare so that we can get better from that population now that we have all the data? Can you think about it? How much data we have in our back pockets? How much data we have on our phones? There is so much out there that if we had no EMRs and we just had chat GPTs, think about it. If I was just able to question and I was able to chat with my doctor, I was able to have an instantaneous AI visit with a doc, how much better would we be? Now, do I need an EMR for that? Seriously not. Do I need to pay for that? Yes. But that my Apple Wallet swipe pay will still work, which is what we are trying to do now with all the EMRs. So what is it that we're really looking forward to? What is it that can change the way we think about healthcare? And the way I think about healthcare is care is for patients. Health is for the community. So when I'm healthy, keep me healthy. When I go to the doctor assumes I'm sick. Can we not perform sick care? Can we perform healthy care? Meaning, give me health, we can make it better for the world. And that's where I think we should look at from an AI perspective. I wouldn't even say AI, the next thing is coming in is people will kill me in this process here. They call it quantum computing. That's the next best thing in the planet, right? And those are the things that we're going to be seeing more and more often. Collectively, our goal is to not make the EHR kill us in the process. Our goal is to eliminate the EHR and call the EHR dead, build a symmetry for it, and go figure out how I can use AI to get healthy, to do more prevention, and get more, maybe, this magic supplements that we get on the street nowadays to feel better. That's, I think, is the goal.
Yeah. That's very meaningful. So we're running out of time, so kind of the last question we'll have for all the leaders in the room. If you had to give them one high confidence move to make in 2026 and one mistake to avoid, what would those be? And we'll go around the horn. Nicole, start.
So probably the move to make would be really developing relationships with your partners, whoever they are, if that's at the same leadership level, if it's one leader down, if it's one up, but really developing those things. And probably the thing to not make a mistake of is leaving out the patient perspective. I also think that's super important. I am a nurse, and so having been at the bedside and in the clinic, I think often we get to this level or we get outside of the clinical setting and we know what's best. And sometimes don't forget to go back and talk to those patients, talk to the customer, make sure that you're meeting them where they are.
I mean, from my perspective, I think the Dr. Glenn Steele mentioned a while ago, 95% of healthcare data is outside of healthcare. And that's very, very true. Do you know that the 95% of healthcare queries that's going into ChatGPT is done outside of healthcare? That's also true. So think about your patient populations, what they are thinking, what they are doing, and how do we help them with better information so they can get better on their own. Yes, we want them in the hospitals. I don't want my hospital beds empty. But at the same time, I want to take care of those acute patients better so when they go home, they don't come back?
For me, I think the one high confidence move recommendation is to move. I think there are a lot of leaders who are in, paralysis of analysis. So I would recommend is to move, take the leap of faith, because the AI ship is no longer, on the beach, sands, getting sun. It's way into the ocean. We're deep into that. We do have a demo session 3:45 where you can experience Gravity, the platform, for all the essence it is. I think the mistake you should avoid is to not move. Nothing grows well in stagnant waters, and we are very intentional and driven that we want data to flow, AI to flow, and we do want leaders and patients to be in the state of autonomy.
I think in picking up on some of the themes, start with aligning around your care model. Technology, AI, is to accelerate and make the delivery of that model, and it doesn't mean just health services, how you show up in your communities. Align around the care model and then be accelerated with technology. And on the other side, don't think this is easy or low cost. There are a lot of hidden costs with going down this road. So there are no silver bullets in this work. Technology will help us. AI is going to be around everywhere. Think about a future where, think about a month ago when Verizon was unavailable. How many people knew where they needed to go next? We've become dependent, and we'll see that. Being able to converse and connect. But it's that humanity of experience in delivering care. And if you're not aligned inside of your organizations around that care model and with your community, all the technology isn't going to make us healthier.
Wonderful. Thank you very much.
Thank you.